Welcome and thank you for joining us for this webinar on disparities in medication access in solid organ transplantation. This webinar is hosted and organized by the TxPharm COP DEIB Workgroup and supported by the AST IDEAL Committee. Before we begin the main presentation, we have a few housekeeping notes to help you in today's discussion. Currently on your screen, there is a viewership poll. Please take a moment to answer this question while I finish the remaining announcements. This webinar is being recorded, and the recording will be available next week on the AST website and hub. Please note that all your lines have been muted so that only the presenters and panelists can be heard for the archived recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A window in the Zoom webinar panel to submit your questions for consideration. Please note that any questions submitted via the chat section may be missed during the presentation. And finally, at the conclusion of today's webinar, there'll be a short survey that will appear on your screen. We kindly ask for you to fill out the survey to help us keep our content current and engaging. And I will now turn the session over to our moderators to begin the presentation.
Hello, I am Crystal Harrison, and myself, along with Rosemary Cross, are your moderators today. I'm going to start with reading Dr. Chisholm-Burns' bio. Marie Chisholm-Burns is the Executive Vice President and Provost of Organ Health Science at University. She is also the J.S. Reinsman Endowed Professor at OHSU School of Medicine and Professor in the Oregon State University College of Pharmacy. She was previously served as Dean and Distinguished Professor of the University of Tennessee Health Science Center College of Pharmacy and Professor and Head of the Department of Pharmacy, Practice, and Health Sciences at Arizona College of Pharmacy. Dr. Chisholm-Burns is the founder and director of Medication Access Program, which increases medication access to solid organ transplant recipients. She's also the treasurer of the Northwest Commission on Colleges and Universities Board of Commissioners and member of the American Society of Health System Pharmacists Board of Directors.
And Dr. Vineeta Kumar. Dr. Kumar is a tenured professor of medicine in the Division of Nephrology at the University of Alabama in Birmingham. Dr. Kumar is deeply dedicated to patient care and serves as the director of UAB's Incompatible Solid Organ Transplant Program, offering her expertise in consultative care for adult and pediatric high immunologic risk organ transplants. She played a pivotal role in UAB's kidney xenotransplantation efforts and paired donation program, helping to facilitate the over 100 kidney transplant chain. Her commitment to compassionate care is further demonstrated through her leadership within AST as the chair of the Education Committee, the Living Donor Community of Practice, the Planning Committee for AST's COP meeting, and more recently was an elected member of AST's Board of Directors. Dr. Kumar has authored over 100 peer-reviewed publications and actively participated in over 20 clinical research endeavors. She lectures nationally with many societies and has mentored countless students, residents, fellows, and faculty over the years. We are privileged to have both of these doctors with us today, and I'll turn it over to Dr. Chisholm-Burns to start the presentation.
Well, thank you both, Crystal and Rosemary. We're just delighted to be here. This is an opportunity for me to partner up with not only a wonderful individual, but a person that I consider a dear friend, as well as a colleague, Dr. Vineeta Kumar. And today we're going to be presenting to you disparities in medication access in solid organ transplantation. So without further ado, let me get my slides turning here. I'm not going to go over this conflict of interest slide with you. You could read that. The slides will be available to you, but I will take the opportunity right now to just tell you how Dr. Kumar and I have this presentation designed. I'm going to go over more of the theoretical underpinning, and then she's going to go into some real live cases. She's going to be facilitating these cases, and then we're going to have lots of interaction. So stay tuned. I don't know if this is a warning or is it a spoiler alert, but either way, we're going to ask you for some audience participation. So stay tuned for that. This presentation has four major objectives. The first is describing how health disparities represent critical barriers to health equity in solid organ transplantation, and I will say especially access to prescription medications in our patient population. Then quickly, we're going to move on from that and go into discussing how the social determinants of health influence disparities in access to immunosuppressive therapy and other needed medications in our patient population. Then we're going to hit some cases. Dr. Kumar is going to facilitate and illustrate issues with medication access via real-life cases that we gathered from the transplant community. So that means from you. And then together, we're going to identify key issues and promote potential strategies or propose potential strategies to mitigate disparities and minimize risk. So let's get started with the first objective. I think it's very important that we get a level set on terminology. So when I think about health disparities, what comes to mind? And this is the definition that comes to mind. I think about preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health. By the way, all of our definitions and our references are at the bottom of each slide. So if you want to take a deeper dive after this presentation, please feel free to do so. Now, this is what we know. Until we eliminate health disparities, we will not be able to achieve health equity. And health equity is health excellence. I'm going to remind you of this quote from the Committee on the Future of Nursing. And this is what they said. They said, a nation cannot fully thrive until everyone, no matter who they are, where they live, or how much money they make, can live their healthiest possible life. I want this quote to resonate with you throughout this presentation, especially as we get into these cases. Now on this slide, I have a couple of examples, just due to the sake of time. 2 examples of transplant medication access disparities. Okay. Again, the studies and the references are on the bottom of the slide. I do encourage you to take a deeper dive into these studies. The first study indicated that Black transplant recipients are less likely than white transplant recipients to receive statins for secondary cardiovascular disease prevention. And what I like about this particular study is they went in and they explored reasons why this might be the case. So possible reasons they indicated was implicit bias, maybe underestimating cardiovascular disease risk, or focusing on non-cardiovascular disease treatment options, as opposed to immunosuppression therapy. The second study, again, a retrospective study, and they looked, and this is at all these prior authorizations that happened over a time period, and this is what they found. They found that Black solid organ transplant recipients and patients in this population that had Medicare and Medicaid had increased prior authorization requirements post-transplant medications. This includes both immunosuppressive therapy and non-immunosuppressive therapy. Okay, and when I think about prior authorization, I think about all the steps that we have to go through. Maybe some of us view it as red tape that we have to go through, and this could lead to delays or even denials. So these are important things. Let's talk about the social determinants of health. Now, we all know that health disparities are influenced by the social determinants of health or drivers of health. Now, when I think about the social determinants of health, I think about many things. I think about conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risk. The social determinants of health are categorized into 5 major areas. I'm going to quickly go through these areas. And so I'm tuning you up for these cases, right? Because I want you to think about these things as we go through these cases that we're going to explore together. Starting with neighborhood and built environment. Here, we think about where people live. What conditions do they live up under? Are they safe? Are they not safe? I know since I moved to Oregon, especially this time of year, we think about air quality a lot. Many of our patients are coming in maybe to just get routine checkups, and we hear their breathing, and it's labor because we have forest fires, right? So air quality, water quality, internet access, very important as we communicate more and more with our patients, right, on platforms such as MyChart, okay? Not only do we have to think about, do they have the ability to access MyChart, but do they have the internet access to do it as well? Moving on to social and community context. Here, you can see what's in the yellow box, but I'm going to bring it home with social support in a few minutes because we know that's very, very important to our patients, their support system. I will tell you, these are 5 categories, and many people like to look at these categories as silos, but they're not. They interact and they bleed together and they influence each other, especially economic stability. For example, I know I do. I get my health insurance from my employer. So if something happens to that relationship, which I hope nothing happens to that relationship, but if something happened to that relationship, right, I would have to think about where I'm going to get not only my insurance, but also my family's insurance. And you might be thinking, hey, Marie, no sweat. You just Cobra it, right? And I say to you, Cobra costs a lot of money. So I would have to, what things am I not going to do with my money, right? Everything is a trade-off, right? What am I not going to do with, what things am I going to let go? So now I can pay these higher insurance premiums. Other things under economic stability. So we see how this healthcare coverage will influence healthcare access. But how about how much money do you make? How much money do you spend? What's your debt load? All of these are very important. Education access and quality. We're going to talk about health literacy. I'm going to show you some studies that my colleagues and I have been involved in over the years. But I'm going to go into early childhood education. And you might be saying to me, Marie, do we have to know all of this about our patients? Yeah, we do. And let me tell you, in this country, in the United States, 3rd grade reading and math scores is a significant predictor for academic success. And we know literacy in general influences health literacy. So we need to know all of this so we can better care for our patients. The last category, healthcare access and quality. We talked about healthcare coverage. And just because I have healthcare coverage, just because we or an individual has healthcare coverage, that doesn't necessarily mean they have great access to providers. It increases their chances. But access to providers, the quality of care is very important. Access to linguistically and culturally appropriate care. This influences communication. It influences trust. And we know trust is the key and the foundation to any relationship, including the relationships that we have with our patients. And then access to preventive care. So I put this model together as it relates to some of the social determinants of health as it influences our patient population with medication access. Now, before I jump into this model, I'm going to ask Rafaela to help me out. I do want to do a poll with you, so get ready to participate. And which of these social determinants of health do you experience at your institution or during your career as a challenge to medication access to our patient population? And you could pick any of these or all of these. So select all that applies. Rafaela, if you could launch the poll. And there we go. I'm just going to give you a couple of seconds to go through this. And while you're putting in your responses or your response, I'm going to tell you that we're going to go through each of these in this model. So I don't know, Rolf, if you're ready to show the response poll. Look at there. You know, what's interesting about this is that, you know, I used to be in practice for a long time. I don't see patients as much as I used to. I'm in a different role. But I would probably check all of these, every last one of them over my career. And it seems like many of you did just that. So that's great. Let's go into the model because all of these are very, very important. Let's start out with drug shortages. Drug shortages. So what does this mean? It comes down to the pharmacy does not have the medication or something is holding up the pharmacist from dispensing that medication to the patient. It might be that it's not in stock. It might be that it's hung up with payer issues, right? But at the very least, it's going to delay that person from getting the medication. And we don't want that to happen. And I know my good friend Vineeta is going to give a case that kind of touches upon this, so I'm not going to go in deep with this. At the very most, it could mean that we can't get that medication and we have to go to an alternative medication. And we've seen this in general. I know in all of our institutions, the big fluid shortage that we all had to deal with and still are dealing with to some extremes. But we also see this with our immunosuppressive agent coverage as well. So I want to give a shout out to the Transplant Pharmacists COP because they help us navigate. We work as a network together to see what's on shortage, what can we do about it. So keep on doing the great job here. Now, let's talk about geographic location and transportation because this is a big access program. What's the distance our patient has to travel to get to a healthcare facility? Right? What's that distance? How about to a pharmacy or a pharmacist? Okay. And we know that we use telepharmacy and we use medicine, but then I'm going to go back to that broadband issue. I'm going to go back to capacity, feeling that that's a good environment. Some people are still resistant to this. Me, I'm all for it because traveling is, I like to do less as possible when I can. But this is not the case with many of our individuals. So we need to think about the individual patient. How about if you live in a rural or frontier area? What does that look like? I could tell you. I've been in many places, lived a long time in Georgia, Arizona, lots of different places, Tennessee. Now I'm here in Oregon, lived in New York, and in each state is different. But I didn't know the meaning of frontier until I moved to Oregon. What does this mean? This means 6 or fewer people in a square mile. Okay, so you're out there. And you could think about there are no pharmacists. There really are no big healthcare facilities. And we're seeing more and more pharmacies close in rural areas. And this leads to pharmacy deserts. And pharmacy deserts aren't just in rural areas. They're right here in urban areas or suburban areas. So pharmacy deserts is a real thing. Getting access or transportation to these pharmacies and these healthcare facilities, it's a real thing to our patients. And I want to talk to you a little bit about home medication delivery. My colleagues and I did a study, and this is what we found. Is access to home medication delivery is decreased in communities with lower incomes, lower employment rates, and increased crime rates. So we need to think about this. Just to demonstrate this, I want to talk a little bit about the medication access program or MAP. And this is a program that I founded back in 1999, and I know I'm dating myself here. But the mission of MAP is to increase medication access to solid organ transplant recipients who live in the state of Georgia. And when we started out, it was really in the major cities in Georgia, right outside of Atlanta, Augusta, Georgia, where the transplant center is located. And what we found early on, and I'm proud to say it today, is that we have patients that reside in all 159 counties in the state of Georgia. And this tells me that all of us, we need to meet our patients where they're at, and they're all over. Education level and health literacy, talked about that a little bit earlier. It's very important, and this will be my soapbox for today, that we talk to patients at a level that they understand. They need to be able to understand us. We need to be able to communicate and understand them. That means that we got to give it adequate time to do that. And we also have to assess their understanding. My colleagues and I, we did several studies dealing with health literacy, and we published on this. And again, the references are on the bottom of this slide. But this is what we found that's critical, especially as it relates to numerical health literacy, is that our patients need to understand the dosage. They need to know how many pills or units make up a dose. They need to know how often to take the medications. And when you can link that with a daily routine activity, like take it with breakfast, take it before you go to bed, link it with a daily routine activity, people are more or less when it's hooked to this activity, they're more or less are able to remember it, right? If you could make the regimens less complex, okay, one time a day, preferably, right? All of this matters. Dosage matters. How often to take the medication matters. How often to refill the medications and that they understand how to do this. Many of our patients use this pill box, so that means they're taking their medications out of a container, putting it into a box. Do they even know what that medication looks like? Because once it's out of that container and is mixed up with 7 or 8 or 10 other medications, it could get very confusing. My colleagues and I found in our patient population, which I submit to you is not too much different than your patient population, is that 72% of our kidney transplant recipients had low to marginal numerical health literacy. So this means we must spend time with them, okay? And we have to assess their understanding. Social support, family, friends, caregivers, and other people who support our patients, we need to make sure they're appropriately engaged, okay? And we need to make sure they understand how to take the medications because they are the caregivers in most instances. This is what we found, okay, when we did our studies. We found that increased social support among kidney transplant recipients is associated with increased immunosuppressive therapy adherence. And we know adherence is associated with better outcomes. Income and employment, I talked about, and I use myself as an example. This is how I have access to health and prescription drug coverage. This would be if I had a transplant or any other health condition, how I'll be able to afford my copays and able to afford everything that supports it, transportation. We know that many of our patients, as it relates to health prescription and drug coverage, they might have a lack of coverage. They might be underinsured. They might have difficulty paying for copays, and they might have caps on prescription coverage. Okay. All of this, to know all of this about the individual is extremely important. And that doesn't mean that you have to know all of it, but you have to have team members where we work together. It really does take a village. We could talk about Medicare Part D here as they changed in 2025. I welcomed the change. I was an advocate for the change, and advocacy is so very important as we think about our transplant population, where we don't have that donut hole that we have to deal with. And what we do have to deal with is our patients out of pocket cost total is about $2,000. And many of our patients might have challenges with coming out of $2,000 out of pocket. Now, of course, you have the initial deductible, which is $590. And then you get into this co-shared covered period where 25% of it is the patient's and 75% is the Medicare Part D, and then anything after 2,000 is covered. And now this is the basic Medicare Part D. So you might be thinking, and I know all of you who do this on a day-to-day, you know this a lot better than I do, but looking at a 2020 study, they found that the first 6 months post-single organ transplant ranges anywhere between, outpatient medications range anywhere between $24,000 to $55,000. And I will tell you that probably most of our patients are on the upper end of that. And we know cost impacts care. A survey of U.S. kidney transplant programs indicated that greater than 70% of programs report recipients experiencing challenges in paying for their medications. About 50% of the programs reported that around 40%, a little bit more than 40% of recipients face barriers in paying for their medications. And this is the take-home message. 68% of the programs report medication access challenges are directly related to graft loss and patient mortality. So it matters. It's so very important. Again, another shout out to my transplant pharmacist COP, especially the COP Public Policy Workgroup in the Transplant Pharmacy COP that worked with micromedics to expand off-label transplant uses for immunosuppressive drugs. I happened to be the board liaison that year that we did this, and I knew this was going to be a big thing because I knew it was going to reduce denials of Medicare Part D coverage. So again, your advocacy is so very important. Speaking of advocacy and interventions, going back to the medication access program, what we do is that we assist with the enrollment in Medicare Part B and Medicare Part D and pharmaceutical manufacturer assisted programs and other programs. And Dr. Kumar is going to touch upon these important programs in one of the cases. And we also assist with medication therapy management. Since its inception of 1999, MAP has helped over 1,170 transplant recipients receive about $130 million in medications. We have published on the outcomes of MAP. I'll just share one article with you. And what we found is MAP patients were associated with decreased blood glucose, decreased cholesterol levels, decreased hypertension, some of those other diseases that are so very important to treat. Also, increased quality of life, decreased graft rejections, and increase in number of medications received. I want to stop or end my official presentation by talking about the Transplant Pharmacy COP Medication Access Workgroup Library, which all of you could have access by using your AST login. And it's really a complete work in progress that we update, and it talks about everything from patient assistance programs to copay cards to challenges that we might be experiencing in different types of situations. So with that, I'm going to turn this over to Dr. Kumar to go over the last two objectives, and we'll do this together. So Vineeta, if you could go ahead and share, that will be great.
Absolutely, Marie. Thank you, Marie. What a brilliant, brilliant presentation. And I'm just struck by the decades of work of your foundational contribution to understanding medication adherence, health disparities, and access to care, particularly in transplantation. And you continue to shape policy, practice, and academic excellence. So thank you for everything that you do to make the life of our patients better. Marie, please stay on. And group, we are going to now talk through practical applications. Marie said she was going to talk about the theoretical underpinnings. And then these are 5 cases selected, and they've been selected by talking to my transplant medicine and surgical colleagues and my pharmacy colleagues. And I really picked cases that are outside of our institution just to show that these issues that we're talking about, access, they're real, and these are rooted in what we face on a day-to-day basis. So let's get started, and then we'll also call upon you to do the polling. Marie already made you practice some of that polling. So this is the first case, again, a real case. This is Mr. Rivera, and he's 63, and he has Medicare coverage. And he has already received a transplant, and post-transplant, as you can tell, has gained a lot of weight and is now actually showing signs of metabolic syndrome between lipids, blood pressure, blood sugar issues. And so he and the provider get into discussion about what can be done. Your kidney is okay now, but long-term, how will it remain okay? And how are you going to remain okay? And what are the options? And together they decide to go along with semaglutide. Now we know that it's approved for type 2 diabetes and weight management, but we are now using it off-label, in this case, to improve transplant outcomes. And so a week later, the clinic receives notification that the prescription that you had written, that this was written for Mr. Rivera, has been denied by Medicare Part D. And the reason it's been denied is it's saying this is off-label use. So in this scenario, please put your thinking hats on. What's the most likely explanation for the barrier, the access barrier that Mr. Rivera is experiencing? Is it just that because it's not FDA approved for patients in kidney transplant, it's an issue? Or is it that you have to have documentation of poor glycemic control before Medicare will approve it? Or is it that this is off-label use and it just creates its own new headaches? Or is it that this is only available through specialty pharmacies and therefore will not be covered under Medicare Part D or regular pharmacies? So Raf, if you could deploy the poll, group, please make your selection at this point, and you click the choice that you think is the most likely explanation. I'm hoping everybody can see the poll. I can see it. Marie, can you see the poll come up? You haven't seen the poll come up on your end? Okay. Raf, we will depend on you to see how many people are voting at this time. There you go. So we have had over 34 of you vote. Thank you for all of you to vote. And interestingly, 50% of you picked that because it's an off-label use, it's why it's triggered denials. And we have some portion of you that say we need documentation of poor glycemic control, and then the fact that it's not FDA approved. So there is a semblance of truth in each one of these options, right? Perhaps, again, the most likely reason here, based on how this case transpired, was the fact that this is off-label use of semaglutide. And why did we pick GLP? GLP-1 and again, agonists are sort of now the talk of the town. Obesity is common, metabolic syndrome is common. That's why this case became very relevant. And the issue here really is that even if we have data that's emerging, even if there is evidence now to inform use of off-label coverage, the reality is that coverage decisions lag behind clinical practice. What we have found, what I have found as a provider, is that in our notes, documenting medical necessity becomes incredibly important because our notes seem to speak for us. And then, yes, absolutely, documentation of poor glycemic control also becomes very, very important. So while all of this is something we can do, what are some other things we can do to maximize the possibility of these drugs that have now shown impact, even in transplant populations, to work? And Murray spoke about advocacy in this field. Murray, would you like to add other aspects of things we haven't covered so far? You have really been heavily involved in the advocacy space.
Yeah, no, Vineeta, I think you did a great job. I think we're going to see more and more of these agents, more and more of the drug companies are developing these agents because there's a real need and it's a market for these. And as this becomes more available, the documentation is critical, as well as looking at how we can make it more available to our patients and covered. That's the key. These are expensive agents when it's not covered. So great job.
Thank you, Marie. And I wanted to also sort of point out to our audience that there's so much that actually can be done. Many of the COPs have formed an obesity group. Recently, a group of us, there was in the Washington Post, an opinion piece that had been presented about the cost of GLP-1s and why it should not be used for coverage. And then a group of us got together and wrote a letter to the editor saying why not all patients are equal and why transplant patients are different and why kidney transplant patients, where it's life-saving, in blocking the use of these drugs could be an issue. And immediately they accepted it, and this was in print. And the more we do things like this, the more we put it front and center, there's hope that while we do our part in clinic, some advocacy work can also be happening in the background. So I just shared that as something that sort of is positive and motivating. All right. Let's look at case number 2. And if you have any residual questions about the first one, we look forward to talking about it in our Q&A portion, which we'll get to in about 10 minutes or so. So here's the second case. And the issue I've already sort of outlined in the title of the slide. But this is Ms. Thomas. She's 57. She has lupus. She's on dialysis. She has no insurance, but she knows, and she's been told that her dialysis dependent status is what's going to get her Medicare. And right now she's enrolled in Medicare Part B only. So she gets in for evaluation for a kidney transplant and is thought to be a really good candidate for kidney transplantation. However, because of limited coverage, now she is unable to get through to get the guideline recommended workup for the rest of the workup for evaluation to be able to get a transplant. So darn here is somebody that we think overall otherwise is a good candidate. So the question to you all is, which of the following now explains, and it best explains, right? Each of them have some truth, but the specific barrier Ms. Thomas is facing. Is it that she's on dialysis and Medicare benefits kick in only when she gets a transplant? Is it that Part B only covers transplant medications but not pre-transplant evaluation? Or is it that Part B does cover pre-transplant services, but not all of it, and the patients have a huge copay? And then, or is it that Part B and private insurance are identical in coverage, but underrepresented patients decline service due to mistrust? So, Raf, if you could deploy the poll again, please. Make your pick. All right, let's see what we got. Thank you again. This is pretty amazing. The consistently, the 33, 34 people voting, and I know many of you are in groups and not a single person in a room. So 88% of you picked the right answer. Absolutely. Medicare. And so you really don't need me to talk about this. This is really your area. You're the experts here. And the issue is, this is something that on the provider side, not all the sort of the physicians and surgeons are fully cued in and aware of this. This is why we need our multidisciplinary care, that while it covers pre-transplant evaluation, it is not full coverage, and there's a huge out-of-pocket cost. And here's an issue of structural inequity. If you are dependent just on Medicare Part B with ESKD and no supplemental coverage, this is disproportionately impacting our patients that Marie showed to us that have issues with social determinants of health, that they're marginalized because of that. And here's another reason why we really need to expand Medicare coverage to include Part D medications and Medigap style supplemental coverage, and not be requiring this high need for enrollment in the Medicare Advantage plans. So Marie, what else would you like to add? Our group is pretty informed, obviously, but you always have insights, so please.
This goes back to advocacy, especially with some concern about some new federal rulings that might come down. We might see this gap actually expand if we don't provide advocacy and really take up and show up for our patients, for all of our patients. And I'll just say it again. A nation cannot fully thrive until everyone, no matter who they are, where they live, how much money they make, can live their healthiest life. And so this is where it really happens at. And this is where we need for you to stand up for all of our patients. And so thanks for that, because we have structural inequities in society. And yeah, this slide right here depicts that. We're going to see more and more Medicare, Medicaid with your arrow going down if we don't stand up for that. So thank you, Vineeta.
Yeah, no, thank you, Marie. And shout out to Bart Crowder, who shared this slide, that even before the recent change came in, between November 2023 and 2024, 7.1 million individuals, the Medicare enrollment decreased by that much. And this is sort of that downward trajectory that Marie's talking about. And so you can only imagine what this is going to look like for our current year and the years to come. And these are all the patients that otherwise we think would have been fabulous candidates, but are just now not going to be able to move through that process. All right, lest you think that I'm completely vetted to kidney. Yes, I'm a nephrologist, but I love all things transplant, and I love all my colleagues in transplant. So here's a case for a liver patient. And Marie actually touched about a change in employer-employee status. And so here's a case illustrating that. This is Mr. Lin. He's 45, and he's had a liver transplant. And because we know he's got many years ahead of life, his team has decided to give him a steroid-sparing regimen for long-term health, and he's on everolimus. And there's really good data now in the liver literature and pretty widespread practice. Now, the interesting thing is, even if he had insurance before, he actually heavily relied on manufacturers' patient assistance programs to cover his immunosuppression therapy. Lo and behold, he loses his job and he loses his employer-sponsored insurance. His family loses it. It's time for that time of the month for him to get his drug refill, and he is not getting that refill because the assistance program for everolimus requires its transition to a more eligibility limited structure. It requires that the commercial insurance has first denied it, documentation of it, and then income verification. And hey, he doesn't have insurance. He doesn't have income to provide any of that. And so he cannot afford the medication. So here it is time for him to fill this medication, and we are batting zero. He cannot get the medication. So what's the most likely systemic factor here contributing to Mr. Lynn's inability to access his transplant medication? And this time, instead of reading each of those options, I'm going to let you look at them. And Raf, if you could go ahead and deploy the poll, and it'll help us save just a little bit time. So please make your selections of which you think is the most likely contributing systemic factor. All right, Raf, let's see what we get for our poll results. Oh, now look at that. The number is increased to 40. And again, we have a very, very well-informed group. You're absolutely right. Medication assistance programs have become increasingly restrictive or discontinued. It's created an access gap for our uninsured or underinsured patients. And when I did a quick poll of some of my colleagues for this question, let's just say that this group did brilliantly compared to the people that I poll. And it just goes to show it's not a world that we necessarily live in. It is something that if you're not aware of, you're not able to screen for as effectively. In transplant clinics or in physician offices where there are lucky enough to have presence of a pharmacist, a physician, a pharmacy doctor who helps sort of look through these things and proactively screens for medication access risks. Great, but not everybody has that. And as a provider, a medical provider, you're not aware of this, and then suddenly the time comes for that medication refill and you lose all the lag time of having known that this person actually lost his insurance. So again, need to proactively screen. Again, going back to advocating for systemic solutions. I really love this idea of if we could be a system where we could create a transparent income-based medication subsidy program for our uninsured patients. And another thought, hey, we talk about metrics all the time. How about using medication access disruption at a quality and equity metric? We've never really thought about that, but now, at least in kidney transplant with IOTA coming in, there is room for us to be thinking creatively outside the box, not as a metric to sort of penalize the transplant community, but as a metric to track, to know as a system, as a nation, what are these disruptions that our patients are feeling? So again, Marie, I would love your insights on this.
Sure, thanks for that, Vineeta. It made me think about how we just need to screen for medication adherence in general, right? And then the barriers surrounding that. So good news, again, help from people like Dave Tabor and other transplant pharmacists. Epic, sometime this year, before the end of the year, is going to have the ITAS that my group put together, that instrument. So the immunosuppressive therapy adherence scale, as well as the immunosuppressive barrier scale, is going to be included in Epic. They're going through the process now of loading it up and getting it out. So you could use it to do those things, because it's very important that we ask the right questions and we ask it often, okay? Because things change. So similar to this case and this illustration of what happened to this patient, things change over time.
Absolutely, Marie. Marie, this tool that's going to be now part of Epic, what is it going to be called? Marie Chisholm-Burns tool of...
No, we're going to leave it as what we named the scale, the immunosuppressive therapy adherence scale, and the called the ITAS or the ITBS, the immunosuppressive therapy barrier scale. But I want to thank all of you for all the work that you helped me to get that scale going and to even get it developed. So it's great to see it.
Immunosuppressive therapy barrier adherence scale. All right. Okay, so we've got 2 more cases. We'll go through these fast. They are kind of related to each other, but really important things. This is something that was in this past year or 2 become really eye-opening for me as to how much of an issue this is. So here's Ms. Gomez. She's young, 29, heart transplant recipient. She just is getting discharged after prolonged hospitalization, and her medication regimen slightly changed from before. She's now on extended release tacrolimus along with her mycophenolate and on antifungal prophylaxis. And her discharge is being coordinated through a specialty pharmacy that has transplant experience. Ms. Gomez has to get going, has to get home, and she trusts her neighborhood pharmacist, and she's like, yeah, I'll just go ahead and get my medicine filled with my neighborhood pharmacy. This is not willful. This is just sort of days getting on late. I have to get going. This is, and so this team that shared this case, was absolutely advocating and supportive of Ms. Gomez and totally protective of, why she did what she did. Now she goes to a local pharmacy and they report issues processing the prescription. And there's all this confusion around national drug codes. And as a result, she now is home and does not have her medications. So again, the same format. What is the most likely reason here? Ms. Gomez experienced a medication access issue at a local pharmacy. And by now you've figured out that these are not necessarily about just knowing what the right answer is, but to really tease through and see that these things actually happen to all of us. We've all seen the cases. And what is the nuance here? What can you, as our transplant pharmacy COP, teach us, the provider side of things, that we also need to be reinforcing with our patients and not just putting all the onus on our pharmacy colleagues? So please make your pick again. All right, Raf, let's see what we have. Great. Again, we have pretty robust participation and everybody picked the right answer. And no surprise, because this is what you do on a daily basis, that specialty pharmacies are just better equipped to handle these complexities of billing and formulary restriction than traditional retail pharmacists. And Marie, I would actually, while we go to this teaching note and people can read this teaching note, this is something you've looked in. I'm just going to go to you and sort of ask you what Ms. Gomez did. How often do you see it and why does this happen?
People have ties to their hometown community, right? I would love to get my stuff, whether it's my groceries or my medications, from the hometown community. And this can, it can be challenging for some of these smaller pharmacies to even carry these medications. It's a lot of inventory cost on the shelf, right? And so it's not just like going down there and getting your Lasix, all right? So it takes a lot of coordination. I would say start early, even with the pharmaceutical manufacturers program, whether it's the pharmacy that you go into, whether you're going to get prior approval, start early. And it's all about documentation, the paperwork. Although I love the pharmaceutical manufacturing programs, as I think about all the stuff you have to prove that you can't get, right? It takes a while. You got to find your income tax returns. Okay, where's my income tax returns from a year ago? Getting all that documentation together just takes a while. And also getting this coordination takes a while, even if it is with a specialty of pharmacy, uh, even more challenging with hometown pharmacies. Doesn't mean you can't do it, just means that you have to pave the way.
Absolutely. So again, on our end, when we do multidisciplinary rounds and we speak with our various teams, from our social worker to our pharmacy to our therapy teams, talking about identifying these needs way up front and starting to work on it way up front ahead of that discharge date. And here's a classic case to show you. And while I'm showing you Mr. Ahmed, who is a lung recipient, I've heard from our transplant community TCAC group, where there's a father of a child who's a kidney transplant recipient who, when they were discharged, had to drive plumb across town to get to a mandated specialty pharmacy. So let's look at this case real quick. This is Mr. Ahmed, he's 52, he's got a lung transplant, and after an admission for a fungal infection, he's being discharged on voriconazole and TAC, and due to his commercial insurance specialty pharmacy mandate, he is required to obtain his medication from a designated mail order specialty pharmacy. And this account has now been set up, he's ready to be discharged, and he really wants to go home. It's going to take a while. And so his family says, we will take him home. We'll figure out a way. We'll pay out of pocket, and hopefully everything will get set up. So 2 weeks worth of medication, they pay out of pocket, and then they're waiting to get their medicines, and voila, they still don't have their medication. And here, again, question to you, what's the most likely systemic level factor contributing to this access issue in Mr. Ahmed's case? Raf, if you could deploy the poll again, please, and everybody please read the options and make your pick. All right, Raf, let's see what the response is. Again, in this group, this is what you are used to doing every day. And while we are absolutely grateful for insurance mandated specialty pharmacies, or specialty pharmacy mandates, because they do know how to work through the system, they do know how to advocate for our patients. Despite that, eyes wide open, especially as medical providers, we need to also recognize sort of the things that we have to upfront be cognizant about, and what that really means as when it comes down to the onus we put on our patients. And these are the things that I learned as sort of teaching points and next steps for myself that I'm now starting to become more cognizant in my own practice. And instead of spending time on this, because you're going to get these slides, I wanted to share with you an effort that was led by the Transplant Pharmacy COP at AST under the leaderships of Karen Khalil and Matt Harris, where they actually polled transplant providers and coordinators about specialty pharmacy mandates and found significant impacts on delayed delivery and care, and a significant financial impact for the patient and sometimes the institution. And now Karen's going to present this at WTC this year. And a part 2 of this is to replicate something like this in our patient population, because this is provider and coordinator perspectives. And this paper has now been written to shout out again to this tremendous transplant pharmacy COP that does so much work behind the scenes, trying to shine a light on so many different aspects. So with that being said, these are just some things we touched upon in terms of access challenges in transplant care, and I won't belabor each of the points, but Marie and I wanted to share these specific key takeaways that you all, this audience, this group really is well versed in. And if you could now take these and share these out with the rest of your multidisciplinary teams that you work with, asking them help you better so that we can all help our patients do even better. So with that, I'm going to stop screen share. Dr. Harrison, Dr. Cross, Dr. Yakubu, if you want to, Dr. Burns, if you want to come online and help us take it through the next phase of this discussion. Thank you.
Vineeta, that was perfect, as always. I always enjoy any opportunity to work with this group and you.
Thank you, Marie, and thank you all. Please take it away.
All right. Thank you so much, ladies, for that wonderful presentation. We do have one question in the chat at the moment, and I think it's directed to Marie. For the centers that do not have EPIC, are there any recommendations how to incorporate something like the ITAS that you mentioned into practice?
Sure. Great. I think even just assessing adherence is important. Ask people in a non-threatening way, a non-parental way, how's it going with your medications? I like refill records if I could get a hold of them, because then you could kind of say, okay, the point is to see if there's any problems so we could address those problems. I know Crystal, this is a reunion for us. Crystal used to work for the Medication Access Program for about 8 years. And this year we let her, when I say let her go, that means she found another job, and I'm still getting over that. But it's great to see her here. But I think having that constant touch with the patient, and all of us are sincerely concerned and want our patients to be successful in their health, is just assessing it. Now, after EPIC gets it up and going, if you don't have EPIC, just drop me an email, because by that point, everybody will have the ITAS and the ITBS, and I don't mind sending you the scale. In fact, in the publications of the ITAS and the ITBS, the scale is there. But the point is just to ask the questions. We sometimes don't ask the question. We assume a lot. Crystal, anything that you could add in? I think it's the frequent contacts, but you'll tell me more about what MAP does with boots on the ground than I would ever know.
No, I agree. I think we just asked a lot of questions, and just eventually we would find out our answers. Sometimes we would go to other centers to see if they had any other input. But yeah, asking questions to talk, making that connection.
Marie, you used the word non-threatening way, asking in a non-threatening way. And you said an open-ended question like, how's it going? I'd love to hear from the rest of the group here who does this all the time. Like, what are some other non-threatening ways you ask for this information? How do you normalize them being able to share back with you issues, concerns, problems that patients have?
I would say that like my interaction starts in the hospital when someone's admitted and I'm doing just a medication history and asking how patients take certain medicines, and it usually will lead you down an avenue where they're like, oh, I take that sometimes, or okay, well, is it supposed to be taken sometimes, or are you supposed to take it every day, or how are you instructed? Well, and then they'll either report if they were having side effects and that's why they don't take it, or if it's a cost issue and that's why they can only take it certain months, or so that's where I kind of get some of that investigation that I can then pass on to the team, that hey, or the social workers on the team, it looks like this patient's going to need some assistance. Maybe we start working on patient assistance programs, or in the state of Georgia, we have this wonderful thing called Georgia Transplant Foundation, but that might be something, go ahead and start getting them access to that. They're going to need it. But that's my general interactions when they hit the hospital.
Great.
Rosemary, that's good, because with MAP, we coordinate with the Georgia Transplant Foundation so they can take care of that bridge. And then by that time, maybe the pharmaceutical manufacturer's paperwork is all settled in. So again, coordinating all of this landscape is very difficult to navigate. It is complex. And so that needs to come out. And just because we do this on a day-to-day, can you imagine being that patient? It's just overwhelming. Idris.
I think Jennifer had something.
Yeah, I was going to say, so I work in the clinic setting, and what's important, I think it is the direct questions asking, because the patients don't realize, like, what are the expectations? What are things that may or may not happen that are going to affect my ability to obtain my meds? So I literally ask, tell me, when did you request refills? Have you missed? I try to be open-ended. Have you missed any doses, and why, what was the scenario? Tell me about it. Let's talk about it. And I think it's important, putting the patient in the center to help them help navigate, like, what are barriers that they experience? What are things that are happening? Maybe they have 3 kids at home that are, all the time needing something, and the ability to keep track of meds and timing, and calling for refills may not be there. And I try to also plan with them, like, for access, trying to get pharmacies that do potentially have automatic refills, or a process that's going to help alleviate some of that, that having to be so proactive to do things. There are limitations in some of that too with the specialty pharmacy mandates, because they have to be with a certain pharmacy. But if they can get text messages that are from that, like CVS specialty, that they'll be able to queue in. But it's direct questions, making sure that you plan together and don't, like, dictate things, but let's plan. Tell me about your life. How do I help you in making this a feasible thing?
Lots of questions have come in, so yeah, I guess that was great, Jennifer. Thank you.
So we do have a few extra questions. One is with case number 1, the scenario. Does AST COP Pharm have any resources to help us navigate insurance denial, especially Medicare Part D? Despite the formal appeal letter, it seems it's possible to get insurance to agree with the emerging data on GLP-1s for weight loss.
Sounds like a project for the TxCOP if you don't already have one. I can say the KPCOP is an obesity work group, and that will be they're very, very vested in wanting to help. And that might be a great cross-COP collaboration to think about if there's not already something in the works in the TxCOP. Somebody's looking for a project. But yeah, Idris, you probably know, Dr. Yakuba, more about this.
There's already some interest in this, and Kataria is leading our work group on this, and I think she's already expressed some interest in working with you, Dr. Kumar, and in terms of how to find the right appropriate wording to in terms of off-label indications for some of these GLP-1s. We know that they have potential role in expanding donor access. In terms of patients that may be morbidly obese that may otherwise would be suitable donors, but also can have significant benefit in terms of post-transplant outcomes. So we'll certainly be reaching out to you, and Qatar is listening in right now, and she'll be reaching out to you about how to collaborate and move forward.
Fantastic. Project 1 already identified. A couple other questions here. Rosemary or Jennifer, do you want to take those? Or I was wondering about medication stock. Do you generally send extra amount of medications at the time of writing prescriptions? I do. It doesn't always work, but that's the short answer. Jennifer, please go ahead.
Yeah, I was going to say, there's some like legal things with Medicare and writing the prescription exactly how the medication is taken. They're for reimbursement purposes for the pharmacy. But if they had, like, not trying to go against what the insurance is trying to do, but some of our private insurers, it is nice, and they're, especially with the CVS specialty and the mandates, that we do try to write for bigger supplies to give them a buffer. Is something that we have navigated before. It's just whenever you have your specialty pharmacy and it's a Medicare Part B, they have much more regulations and coverage. So there's some navigation pieces there to kind of be mindful of.
Yeah, I would say at our practice, we do not write for more when it comes to at least like the CNIs, tacrolimus. We do get around a little bit with the antibiotic prophylaxis, say like the Bactrim or Valsite, that we will write for, what the dose we know that they'll get to eventually, but then we renally adjust right when they're discharged. So they usually get a good supply, and then it can last, getting around that requirement.
I think we're 4 minutes over the hour. We have a few more questions. We can either, Raf, you think we should try to answer these now, or should we send a written reply to some of these questions later? Yeah, we'll take our direction from you, Raf.
If you guys would like to answer the remaining two, and then we can wrap up if you all have time. If not, certainly want to be respectful of everyone's time. We can follow up after. So I'll kind of leave that to you both all.
I'm happy to stay on if that helps to answer. Marie, and how about the rest of you? Yeah, okay. All right, so I guess as we all see more and more patients with limited staffing, what system for providing enhanced education have you found effective? Golly, this is such an important question, and this is something else that we can all collaborate on. Absolutely. If you want to do the appropriate education, you become the bottleneck in clinic, either in the inpatient setting or outpatient, right? And if you are efficient, efficiency and speed doesn't always mean it's effective, right? So it's sort of picking your, so what I have learned from hearing Marie is we don't have to do everything every time. It could be a flavor of the month or a flavor of the visit, or, you have your key things that you want to talk about at every visit, but then hone in on specific things, for like identify a specific thing for every visit. I have found that increasingly pamphlets and flyers and those kinds of things are not working. It's just sort of information overload. So it's really meeting the patients where they are. For me, it starts with a really open-ended question. It says, look, many of my patients, it's really hard to take meds and they miss pills. And I know if I had a transplant, I'm missing pills. So like, does this apply to you? How often does that happen? Or how hard is it to pay for your medications? Or what's your copay like? Like, how much are you paying? And what, is that money you could use in other places? What are your pain points? And just sort of sitting back after opening that and letting them just talk and listening really intentionally and listening to understand, not just to respond, right? Like we've heard that, but really paying mind to that sentiment and then saying, okay, where does the education come in now? Where is it really education? Because I can only educate if I understand first what the issue is. So that's my way of probing and getting them to tell you what is it they need, as you had said earlier, Jennifer. But would love to hear other inputs, especially with this limited staffing and what systemic intervention we can do.
Yeah, just to add to that, Vineeta, I think that taking a multimodal approach, right, and using technology in our bed. These patients are typically in a waiting room or in some type of waiting pattern, right? And I learned from my oncology people is that they pass around these tablets, right? You're gonna have to monitor the tablets, right? They pass around these tablets, and it has cartoons and all sorts of things of how to take your medication and what they just simplify it, 3 or 4 bullet points. It has TVs up there in the waiting rooms, talking about different things. Now, this is the shotgun approach because you're not, doing what you're doing, narrowing it down to the individual, but the more they hear about it, the more they can come in and ask questions. Well, I saw on that TV and hey, that didn't look like what you didn't tell me that last time. You told me this, at least I thought this. And so assessing all of these things, using technology, screening tools, empowering others, and working through others. We cannot, I think one of the things that we do, and maybe the way we've been trained, especially with HIPAA and stuff like that, and all that's appropriate. But sometimes we leave the caregiver out of it. And then sometimes we do the exact opposite. We only talk to the caregiver. And I'm like, the patient like, hey, I'm over here. I hear what y'all saying about me. And so how do we make this a family affair? How do we engage and empower others? And how do we utilize what I'm going to call downtime to the fullest advantage. So I think it's a mixture of all of that, and it's very multimodal.
So thank you to, I guess, Lara and Few for asking your questions, and then our anonymous attendees. And this last one, I guess we could actually all try to answer with the yes or no. This last question is about this person asking, our institution has struggled getting medication access to medications that they were previously receiving from a drug manufacturing company. And now that option is not available. Patients are on stable therapy. They cannot afford the drug. Has anyone else encountered these issues? On the count of 3, let's do show of hands for who's encountered this issue in the 6 of us. 1, 2, 3. Oh my God, all of us. So yes, this is sort of not an uncommon issue. So Jennifer, Idris, Crystal, Rosemary, Murray, what do you do? I just am trying to find for a cheaper alternative and explain to the patients. I hope I could, but at least something better than nothing. But please, Idris, you unmuted, so go for it.
That comes to mind is tacrolimus products. So patients that may be on extended release tacrolimus products through manufacturer assisted programs. Oftentimes switching them to generic or immediate release tacrolimus is typically the best options. And for institutions that have their own specific sort of indigent programs, access programs, they may not have some of the extended release products on formulary for patients to have access to those institutional-based access programs. So switching them to something that may be on formulary that the patient can take advantage of whatever access programs those institutions have, is an option. And also looking at, other options for medications, so obtaining medications like, cost plus, as well as, with RX, you may be able to find, cheaper options from those access options as well.
All right, I guess we're 11 minutes past the hour, so we should end this. But yeah, I'll turn it over to our wonderful moderators and planners of the session. Yeah. So who wants to do closing before we say bye to everybody?
So I can go and just thank everyone, all their panelists, and for our attendees for today's session. And for the attendees that are still on, please remember to complete the evaluation survey that will be coming your way. The recording of this session will be available and will be posted on the AST YouTube channel next week, and also the hub as well. So thank you again.